Good morning, everyone. Sorry for the delay. Give us just 1 second, 1 moment, please. Hi, good morning, everyone. Thank you for joining the Take 5 How eCQMs Improve Patient Care and Outcomes webinar. My name is Christy Washington, and I'm the Pop Health Analyst for Health Information Technology here at DCH. I will be your moderator for this webinar. This is part 1 of a 5-part series where we take a closer look at 2 eCQMs to provide the benefits of entering your clinical quality measures and how it will aid in providing quality health care to Georgia's Medicaid population. Jeff Jacobs with DXC Technology will present an overview of the project, followed by a system presentation by Teresa Harris, also from DXC. Chris Huckabee with Health Tech Solutions will present 2 of the eCQMs for preventive care and screening, and Dr. Dan Roach will share his thoughts during the clinical perspective. Before we begin, I would like to remind everyone of a few housekeeping rules. Please hold all questions until the question and answer session. At that time, please raise your hand and we'll unmute you to ask your question. You may also type your question in the question pane and we will read your questions out loud for you. This presentation is also available to download. It's in the handout section. If you are unable to download this presentation, please send us an email at hit.info@dch.ga.gov. Again, that's hit.info@dch.ga.gov, and we'll be happy to send you a copy of today's presentation. This webinar is also being recorded. The recording and the presentation will be available on our DCH website. You can just search for GA-CQMS and it will take you right to it. There will be a brief survey immediately following this webinar, and we ask that you please take the time to complete that survey. At this time, I will turn it over to Jeff Jacobs.
Thanks, Christy. Again, this is Jeff Jacobs. I'm the Account General Manager with DXC and appreciate the opportunity to share with you about our project. And so we'll jump right in. Here you see the mission of the department, and obviously focused on providing access and quality health care to Georgians through effective planning, purchasing, and oversight. Our goal from a project standpoint is improving access and ensuring quality to strengthen the communities we serve. So Christy's kind of covered the basics of what we're going to do. It's a little bit different than our typical format. We'll do a little bit of a deep dive into a couple of the measures. So let us tell you a little bit about the project. So our project, and the goal of this conversation is to share with you about our project. And if you are interested in participating, we continue to look for folks that may be interested in participating. It's a volunteer-only project, and so we're excited about sharing with you the activities that we have underway. So our bottom line is to implement and operationalize a way to accept clinical quality measure information in a number of different formats. We've implemented, so now we're in the operationalized stage. We're going to take that information and we want to make useful use of that data, make the data useful to both providers in ways that they can see it when they log into the application, and useful to the state as they may look to gain insight from the information and influence future program activities or maybe intervention activities where may be needed. The application has capabilities that allows us to look at the data in a couple different ways, right? So that we can assess against member and disease categories, compare provider geographies or different provider types. So a great tool and a great way to gain benefit from use of data coming out of our certified EHR systems. Okay, so we've got a little interactive area of the presentation. And so you'll see there's an opportunity to participate in the poll. And so the question for our first poll is your practice currently looking for an effective way to capture clinical quality measurements? So if you'll take a second and indicate yes or no. Again, is your practice currently looking for an effective way to capture clinical quality measurements? Okay, and so we have a number of participants today that are participating from the department and the project team. And so really encourage those that are outside of the department. We appreciate your feedback on these polls. So thanks. We'll move on to the next slide. Okay, so ultimately our project is going to benefit in improving health outcomes for Medicaid members. Our stage of the project right now is about learning lessons from efforts to engage providers and gain their participation in the project, learn what sort of barriers or challenges we face in getting folks enrolled, and enroll is not the right word, registered, as we collect initial clinical quality measure data. So the platform ultimately is rules driven. It's based on standards, national standards. Frankly, we're using CMS, clinical quality measures. And, you know, as the industry moves in a different direction, right, as the industry begins to move from fee-for-service and volume-based reimbursement patterns and moves to value-based reimbursement patterns and looking at outcomes to determine the success of its efforts, ultimately these kind of tools become very helpful and useful as we use data to drive program initiatives and improvements. Okay, poll time. Back to the second question. So the second question is, would comparing provider data to state average data benefit your practice? So to get a sense of how your providers and their individual clinical quality measure results may compare against state average data. So we'll give folks a chance to respond to the poll. All right, great. Thanks for your time in responding to that. Looks like we have 100% agreeing that it would be helpful to compare provider data to state average data. Well, lucky for us, that is exactly one of the capabilities that we have within the application, is the ability to compare provider data against state average data for the clinical quality measures that we're collecting. So let's be specific about what the project offers, right? So at the end of the day, we're hoping to engage with providers that have EHR systems in their environment and the ability to generate clinical quality measure scores and results. We can accept that data through manual entry. We've got essentially a website with very simple entry of data, or we can collect it through an EDI file that we refer to as a QRDA Cat3 file. That's an HL7 derivative. Again, a standard way to report those measures. We display the measurement data through a graph format. It includes a comparison against state averages. And one of the things that we've learned, our goal is to limit time required for participants, right? So we know that you have several day jobs, maybe some night jobs and some weekend jobs in terms of all the activity that your practice supports. So we really want to emphasize limited time required for your participation in the project. And so we've gone so far as to will assist with the data entry of the information. So if you can generate a report of the clinical quality measures, we'll take that and use it to enter the data, and then you'll have visibility to it to assure that we've entered that correctly, and then we move on from there. We collect the data quarterly, so it's a single activity each quarter to collect the reports. We're not collecting member level data, we're collecting member aggregate data. So at the end of the day, there's really no PHI involved in this approach. If you're familiar with these measures, they're very straightforward measures, and we're going to talk about a couple of examples in detail. But the result is you get a numerator value, you get a denominator value, you may have an exception or an exclusion value, and then you're off to the next measure. So it's very straightforward to participate. Okay. We also benefit from the participation of a clinical advisory board. One of those clinical advisory board members, Dr. Dan Roach, is going to speak in just a minute and share a little bit of a clinical perspective. But this makes sure that from a project team, from a planning, from a consideration, from a strategy standpoint, we're engaging with the clinical perspective. These are folks who have active practices, and we have a number of participants that are participating and including feedback and input from the department's quality team. And so we appreciate all their participants. And again, we look to the project participants as well to really participate in a similar way as time permits, right? So we want feedback, we want input. That's the stage that we're in this stage of the project, this phase of the project. All right, next up, hey, it's polling time again. We've got two more questions. This is our third question so far. And the question is, would you utilize trend analysis or reporting to monitor population health? Would you use trend analysis or reporting to monitor population health? Again, this is a great tool that provides some of those capabilities. Looks like we are all yeses on this question, so we're 100% yes that you would use trend analysis or reporting to monitor population health data. So let's talk specifically. We're not a project that's focused on huge numbers in terms of participation. We really want to engage directly with folks that are willing to participate. And so we have 7 participating provider organizations at this time. Some of those participating organizations have 1 or 2 providers that are participating. Some have 10 to 15 providers that are participating. And there are some even larger. Right now we have 7 CQMs in the system. We're going to show you that in just a second, which measures we're measuring. One of those will be removed, and it's going to be removed because, frankly, CMS has removed it from its list, primarily because it's almost consistently 100%, and it was an asthma-related reporting. We are seeking data to be loaded quarterly. As you may know, on the Medicare side of the house, I believe they collect information annually. You will see in a lot of these projects that are very focused on collecting this data, they're looking to move to more timely input, quarterly, even monthly. But right now, we're not there yet on the monthly side of the house. We're very focused on the quarterly side of the house. Okay, so these are the specific measures, right? And just in case you've dialed in, so we are using the standard CMS measures. Those measures are CMS2, related to depression. These sort of try to span various areas. Some folks have given us feedback that maybe not all of these apply to their practice, and we expect that. We really know that you may have just 2 or 3 of these that you're providing metrics on. That's great. That's fine. we'll take whatever volume is natural to your practice, right? And so you see here we've got some depression screening, some BMI screening. Some of these are some of the standard things that are measured and tested at each delivery, and then there's some exceptions, right? Maybe related to a disease state around diabetes or breast cancer screening, high blood pressure, and then chlamydia screening for women. We are going to be adding some new measures. I think that's the next slide. A lot of the feedback that we've been given are around pediatric practices and some of the measures that are more focused on some of the children. And so you see here we've got a number of child-specific measures. Give you a second to look at those. Okay, and then I think we're back to our last poll. So I know some of y'all are disappointed that we're at our last poll, but if you're not disappointed, this is also the last poll. Has your practice spoken to your EHR vendor about QRDA files for clinical quality measures? A lot of the systems, we expect the ability to generate a QRDA file is standard for EHR applications. And again, that's the EDI file, the standard EDI file that reports clinical quality measure data. And so we expect that's a capability of most systems. Even if it's not, that doesn't preclude participation in the project. It looks like that is not common for our participants today. And so that's just an easy way to report the data, but there's also other easy ways to report the data, and that is the generation of a report or manual generation of that data, and then we can enter it for you, or you can enter it through our website. So let's show you a little bit of the system. Teresa Harris, our project representative today, is going to share a little bit about the project, specifically show you a little bit. Teresa?
Good morning. Welcome to the Georgia CQMS webinar. The first screen that you're seeing for this presentation is the actual login screen. So once you start to participate in the program, you'll be provided a login and password and the link to get to the website. So this will be the first screen that you see. Once you log into the system, we are very excited about the presentation of the next screen. Once you log in, you will be displayed a dashboard. On that dashboard, you'll be able to see the state average for Georgia CQMS. You'll be able to also look at the state average versus the CQM average for your practice. For example, if we look at CQM 125, you can see that the state average is at like 56%, and the average for your particular practice may be at 52%. So that's just an example. This is just employee data that we have in the system. Also, on the left-hand side, you see different options. You'll be able to add CQMs. We have a couple of options that you can add CQMs into the system. Okay, so before you go there, another example is if you click on one of the CQMs, you have a trending graph. The trending graph will just give you an example how well you're trending, your CQMs are trending for that particular year by quarter. And so within the Georgia CQM system, we do collect the data on a quarterly basis, which gives us a little leeway to kind of analyze the data on a quarterly basis. Right. On the next screen, you see a stratum. The stratum we have displayed because some of the CQM measures that CMS has identified requires a specific calculation of stratum data. So you have the option to click on the measure, and the stratum information will be displayed. All right, so on the left-hand side, if you click the Add View CQM option, you'll be displayed an option whether you can enter the information manually or the QAD-CAT3 file example as Jeff had mentioned earlier. The next screen that you see currently is an example of the screen that will display, allowing you to enter the information for your CQM on a manual basis. The screen here allows you to enter your numerator, denominator, any exclusion information, and any exception information that is required based on that CQMS. Now, once you've had all your CQM data entered, the system will display a summary screen, and here you can look at it, just a visual of your summary of the information that you entered. For example, you can see that for CMS2 ID, you had numerator of 12, denominator of 25, an exclusion of 2, an exception of 1. So this is a great summary screen to go back and view once you enter your CQM data. Okay, so thank you for your time. We are really excited about the Georgia CQMS. We think the system is very flexible of collecting your CQM data. And once again, the dashboard is a big hit right now with the Georgia CQMS. Thank you.
Okay, so now I want to invite Chris Huckabee, who is a practicing nurse practitioner in the beautiful state of Kentucky, to share with us a little bit of a deep dive on a couple of the clinical quality measures that we collect. Chris?
Thank you, and good morning, everyone. The first measure that we would like to take a deep dive into is CMS2, Screening for Depression and Follow-Up Plan. The measure description is the percentage of patients aged 12 years and older screened for depression on the date of the encounter using an age-appropriate standardized depression tool. And if that screening is positive, a follow-up plan is documented. For the denominator, we have all patients aged 12 years and older at the beginning of the measurement period with at least one eligible encounter during the measurement period. The numerator would include patients screened for depression on that date of the encounter using an age-appropriate tool, and if this is positive, a follow-up plan is documented on that date of the positive screen. The age range for this measure will capture pediatric adolescents through adults. Next slide. So who is excluded from this measure? Will be those patients who already have a diagnosis of depression or those who have been diagnosed with bipolar disorder. The denominator exceptions include those patients who refuse to participate or are in an urgent or emergent situation where time is of the essence and delaying treatment would jeopardize their health. Or they could be in the situation where their functional capacity is impaired, and that would impact the accuracy of the results of the assessment tool. An example of that could be like a court-appointed case in the case of delirium. So when does the documentation have to be done for an encounter to count in the numerator? The numerator statement for this measure specifies that the patient must be evaluated using an age-appropriate standardized screening tool of the provider's choice. If the initial diagnosis is made or the assessment is positive for depression, a follow-up plan has to be documented for that current encounter. And a follow-up plan can include additional evaluation for depression. For instance, if you standardly in your practice use a PHQ-2 and the answers to those questions are positive, you could document that you followed up with a PHQ-9. You could also do a suicide risk assessment. Maybe you could refer to a practitioner, a behavioral health provider, or you could initiate the pharmacological interventions yourself, like an SSRI or a TCA. And any other interventions or follow-up that your practice uses as standard protocol. It's important to remember that the name of the screening tool that you use must be documented in the medical records. Clinicians should routinely screen all adults for depression using a standardized assessment tool. And for those that are positive, the clinician should establish and maintain follow-up with those patients. The clinician should screen and monitor the depression of pregnant and postpartum women. And the patient screen is required once per measurement period. Therefore, it doesn't have to be documented every time a particular patient has an encounter. Next slide. So how will having aggregate data help me to improve the care to my patients? So when I log into the Georgia CQMS, the provider's landing page is this dashboard that you see. And I can see fairly quickly that I'm doing a little bit better on CMS2 than that of the state average. So in other words, I have identified more of my patient panel that had an encounter during this measurement period as having depression, and I have documented a follow-up plan. Well, and that can be anything, again, as scheduling the patients for further evaluation, referring them to behavioral health, or starting that medication myself. The second thing that I can see rather quickly is that I'm at 32%. And the question that I could ask myself is, am I happy with that number? Would I like a higher percentage? So I should be thinking along the lines of, am I ensuring that during all the wellness exams for my patient panel, am I at least administering a PHQ-2? Next slide. So this is a trend graph, and as Teresa had pointed out, this shows for CMS2 my trend over the last 4 quarters of 2018. Next slide. So the second measure that we want to dive into is CMS 69, body mass index screening. As you can see, the measure description is the percentage of patients ages 18 years and older with a BMI documented during the current encounter or during the previous 12 months, with a BMI outside the normal parameters, and the follow-up plan is documented either at this current encounter or during the previous 12 months of the current encounter. And so the normal parameters are for age 18 years and older is a BMI of greater than 18.5 and less than 25. So our denominator will hold all patients 18 and older on the date of the encounter with at least one eligible encounter during my measurement period. The numerator will hold those patients with a documented BMI during the encounter or the previous 12 months. And when the BMI is outside of normal parameters, I have a follow-up plan is documented either during this encounter or the previous 12 months of the encounter. Okay, next slide. So our exclusions for this measure would include those who are pregnant. We don't do a BMI on those who are pregnant. Patients who are receiving palliative care, and those patients who refuse their height and weight, or both, or they've refused follow-up care. The exceptions can include those with a medical reason, and so this can kind of be those patients say that they're in a wheelchair, or they have some disability that where obtaining their height and weight may not be possible in my current care setting. And also it's going to include those who are in urgent or emergent care situation where delaying treatment would jeopardize their health. The measure timing for this measure differs a little bit from the last measure. There must be at least one eligible encounter during the measurement period, but the documentation of BMI and follow-up plan can be done either at this eligible encounter or within the previous 12 months. So an example of this could be the patient is seen say March 18th, 2019, and the BMI was documented March 30th, 2018, and it was abnormal, and the follow-up plan is also documented, that would meet the numerator criteria. As long as the most recent BMI and follow-up plan are documented within 12 months prior to the eligible encounter or at that encounter, this meets the numerator criteria. The general guidance for this measure is there's no diagnosis. There's not a diagnosis code associated with this measure. The measure is to be reported once per reporting period for those patients who have an encounter, and may be reported by those EPs who perform the quality actions described in the measure. EPs are required to measure both height and weight within 12 months of the current encounter, but height could be obtained on one encounter and weight can be obtained on a separate encounter, and they cannot accept self-reported values. So what that means is the patients can't tell you their height and weight. It has to be measured by a medical facility. The BMI may be reported in the medical record of me, like the EP, or outside medical records, like it could come over on a summary of care document. If more than one BMI is reported during the measurement period, the most recent one is used to determine if the performance has been met. The documented follow-up plan must be based on the most recent documented BMI that's outside of normal parameters. And a follow-up plan for this could be the patient was referred to nutrition counseling for a BMI either above or below the normal parameters. Next slide. So going back to the question of how can having this aggregate data help me to improve the care of my patient? Again, this dashboard is a quick reference, and I can see fairly quickly that I'm doing a little better on CMS 69 than the state average. And I am documenting a follow-up plan, or whatever that may be. The second thing that this lets me see rather quickly is that I'm at 75, 76%. So what does this number tell me? Am I happy with that number? 3/4 of my patients have a BMI that's out of range. And although I have documented a follow-up plan, this kind of gives you some food for thought of what can I do to help my patients get their BMI back in normal range. Okay. And Jeff, that is all that I have for our deep dive. Oh, and there's a trend graph. Yes. So I can see my.
Okay, Chris, thanks so much. That was a lot of good detail about the two measures, and obviously there's more of that on each of the measures. There's a lot of reference data available, and we're available to help with any questions there may be on those measures. Okay, so let's switch gears to Dr. Dan Roach, a member of our Clinical Advisory Board, and just get a little feedback from Dr. Roach, and then we'll open it up for questions and wrap things up. Dr. Roach?
Okay, thank you so much. Good morning, everybody. So I'll be very brief this morning, but we hear, a lot about the switch from fee-for-service to a more value-based reimbursement model. And I'd just like to spend just a couple of minutes talking about the CMS quality strategy goals. I think we've heard of the triple aim of, lower cost, better healthcare, and a better clinical experience. But I just want to spend maybe a couple of minutes going into that a little deeper, and just even read the mission statement to kind of give you the background of where this is coming from, what's driving, the Medicaid agencies to adopt this more of a managed care value-based reimbursement model. So the mission statement for the CMS quality strategy goals says this. It says, to optimize health outcomes by leading clinical quality improvement and health system transformation. And in addition to the three of the triple aim, there are actually more like 6 goals and objectives. And they are to make care safer, strengthen the person and family engagement. So, including people, not just the patient, but involving their families and getting them to be partners in the care of patients. Promote effective communication and coordination of care, so looking across different care platforms, whether it's the physician's office or some care management organization or palliative care or whatever it could be, to coordinate that care across all avenues. To promote effective prevention and treatment of chronic disease, so again, focus on prevention rather than being proactive rather than reactive. Working with communities to promote best practices of healthy living and to make care affordable. I've done a lot of quality measurement work in the past, and we've always used claims data. And claims data is good because you can measure if things are being done or not, but it's very limited in that you don't know what difference you're making. And with all of these objectives and the new push for even looking at social determinants of health, we're going to have to get into the clinic, into clinical data, and to identifying ways that you in the clinics, at the point of care, can have identify opportunities to improve, the life of a patient, and to be able to measure that so that we can look at it objectively and find gaps where we can make some changes and improve the quality and the management of the overall care of a patient. And in order to be able to achieve these shared savings goals, well, you frankly have to know where you stand. And data collection and analysis are really the heart of that piece of it. So, these systems like this that we're showing today and others that collect this information are not just there to collect the information for reporting purposes, but they're also there for you to help you see how you stand and to find ways to act on that information, make decisions on that information, make changes within your practice or changes within a single patient to affect some positive change on the care and the outcomes that patient experiences. So the goal is for as many people to use it as possible, but also because that will give us more feedback to make it a better system for you as well. So I would say we welcome any and all feedback along those lines, because this really is for you to help you see where you stand, and then also to affect a positive change to help improve the lives and the health of our patients. So that's really all I wanted to say, just kind of very, very brief, but a lot of information. So I would, welcome any questions that anybody has, if you want to send them in or whatever, however we're going to do questions.
Dr. Roach, thanks so much. So let me open it up. We'll open up the lines for folks. So all of the attendees, we've had your phone muted, and so now we're going to unmute your lines. You, of course, can continue to mute your lines, on your phone directly if needed, but we'll take everybody off mute so that we can receive questions. And so any questions? And actually, you can also put questions in the chat room, right? There's a question thing. You can raise your hand, a little hand raise capability. I do want to share one thing that got a great response at the Medicaid fair that we just held, where we had a similar discussion. And, one of the things that we know that is not on our provider community's top 10 list of favorite things is HEDIS season, when we have those hybrid measures that require the review of a medical chart and making assessments about whether or not a particular HEDIS measure was met. The state on an annual basis will review anywhere from 5 to 10 to 15,000 charts as part of that activity. And that can be a pretty big inconvenience cost in terms of copying charts, et cetera. And so we do expect that as this progresses and these become more standard and useful, that we'll be able to move away from chart reviews and leverage tools like this, clinical quality measure tools, and their measurements to capture the data rather than come out to provider offices and inconvenience operations, right? So excited about that potential in the future, and so again, you know, I think that's all more of an effort to move away from paper processes and move to electronic processes. Okay, so again, opening up for any questions folks can type. We can go in any direction. You can ask a follow-up question about the system that we reviewed, that Teresa talked through, anything about the project, or anything from our clinicians participating today. I'll pause there to see if there are any questions. And again, we did attempt to unmute everybody, but please use the question or the chat feature just in case. If not, if there are no questions, we really appreciate your time today. We know you're busy, and we hope that you might be willing to participate, or maybe you want to learn more. We are happy to meet with you one-on-one and talk through any additional details or answer questions you may have one-on-one. You can email us at the email address that's on the screen now, just in case you can't see that. It's gacqms@dxc.com, or you can call us, and project representative Teresa Harris will follow up with you at 866-211-0949. Last chance for any questions. We will have additional webinars in May and June. You see the dates there. We'll send out invites, very similar discussions. So best bet for those that have already participated may be just to reach out to us if you have interest. Again, we really appreciate your time, and thank you for your attendance today. Thanks all.